All right, guys, today let's take a look at chapter 13. In chapter 13, we are going to take a look at your role in the diagnosing of infectious diseases. We'll see in this chapter, we'll talk about how even though it's not necessarily the nurse's role to diagnose infectious diseases, of course, that's going to fall on the clinician or physician, but we have a big role as nurses to make sure that we are taking in the signs and symptoms that a patient is displaying when they come in with an infectious disease. And then utilizing what we know, our knowledge of infectious diseases, and then going ahead and running the proper tests. So it's really kind of our role to make sure that we're selecting the proper specimen to collect, that we're collecting it properly, and then we're transporting it to the lab. So then the laboratory professionals have a very big role in this as well, as they are going to observe what virus or bacteria or fungi that they are looking at under the microscope that is causing this patient to have these signs and symptoms. So they too play a role. And again, what happens is, as the nurse and then the laboratory professional, we will pass on our information to the physician, and they will then eventually make that diagnosis. Okay, so let's take a look about at that chapter. So here again, we are taking a look at chapter 13. All right. So chapter 13, again, diagnosing of infectious diseases. Our outline for this chapter, as I mentioned, we're focusing on the clinical specimens. So again, the role of healthcare professionals in this process. So again, in the submission of these clinical specimens. We'll talk about the importance of high quality clinical specimens. As I mentioned, the selection, collection, and transport. So again, we have to make sure we're picking the right specimen for whatever's happening to this patient. We are then collecting it properly, and then we transport it to the appropriate place. Contamination of clinical specimens with indigenous microflora. We'll talk about how to avoid that. We'll talk about different types of clinical specimens. So real general things you probably already are familiar with. And then we'll end with talking about where these clinical specimens are going to be transported to, and that is the lab. So again, the lab is, again, the pathology department. So we'll talk about real briefly, we'll take a look at the difference between clinical and anatomical pathology. And then the clinical microbial laboratory is again focusing more so on not just diseases, but specifically more so infectious diseases. Okay. So the proper diagnosis of an infectious disease, one, as you know, we have all been to the doctor's office, and we know these things are what is going to take place. Anytime we go into the doctor, our kids go to the doctor, and now as people who work in these facilities, we know that these things have to take place. One, you take a complete patient history. We want to know if what's happening with the patient could be because of genetics. We need to know, if, mom, dad, maybe grandfather has this particular, any type of genetic disorder that could be passed on to now our patient. So a patient history, but that also includes anything that they've been through, any type of surgeries that they've had in the past. And again, just to see if it could be something that they've already been through that could be causing this. Conducting a thorough physical examination of the patient. So again, taking their height, their weight, talking to them about, their smoking, their alcohol, their nutrition habits, things like that, just to see what their lifestyle is like, so we can see maybe if that might be causing anything that could be going on with them. Carefully evaluating the patient's signs and symptoms, taking a look at why is the patient here today? Why are they visiting us? What seems to be going on? So we take a look at their signs and symptoms. In the next chapter, we'll actually take a look at the difference between those two terms. Signs and symptoms we oftentimes use synonymously, meaning we use them hand in hand, but they're actually a little bit different, and I'll show you that. And then again, we implement the proper selection, collection, and then transport, and then processing of these appropriate clinical specimens. So what is a clinical specimen? So a specimen collected from the patient, such as blood, urine, feces, cerebrospinal fluid, these are all known as clinical specimens. Those couple are just your most common. But clinical specimens, there's actually a very wide range of clinical specimens that we can collect from patients to help us figure out what is happening with the patient. So some commonly submitted to the hospital's clinical microbial laboratory, again, the lab, which is kind of focusing on infectious diseases, so dealing with microorganisms. This includes blood, as we already mentioned, but also bone marrow, bronchial washings, sputum, CSF, which is cerebrospinal fluid, cervical and vaginal swabs, feces, hair and nail clippings, pus, skin scrapings. For some reason, sputum is mentioned again, synovial fluid, throat swabs, like for strep throat, tissue specimens. If there's an infection taking place at the skin, we can actually take a sample of that tissue. Urethral discharge material, urine, and even urogenital secretions. So there's a whole range of things that we can take from a patient to help us figure out what is happening with that patient. And always, all specimens should be of the highest possible quality, meaning, and we'll talk a little bit about that, meaning that we don't want them to be contaminated. We want to make sure we have a good amount to make sure that it can be read by the laboratory and things of that nature. So we'll talk about that a little bit more so. So your role. So the role of the healthcare professional in the submission of these clinical specimens, there should be a close working relationship among members of the healthcare team. So even in these different departments, to ensure a proper diagnosis. So meaning we work together with the physician that is actually going to be the one who is diagnosing this patient. We work hand in hand with the laboratory, making sure that we are, again, transporting them the proper clinical specimen and then working with them about, what they're looking at. So we're working with different departments as well as the people on our team to make sure that, we're going to ensure this proper diagnosis. Healthcare professionals who collect and transport specimens should exercise extreme caution always during the collection, one, so that we don't hurt the patient in any way. Again, if we are having to take a blood draw or a tissue sample, we obviously don't want to hurt the patient during these because they can be painful if not taking, proper precautions. But also to make sure that they're not contaminated in any way. In the proper, in the transport, we make sure that nothing gets into that clinical specimen, to make sure that that reading is completely accurate. So in the laboratory as well, all specimens are handled carefully, always exercising standard precautions. So as I mentioned before at the very beginning, although laboratory professionals as well as nurses aren't necessarily making those diagnoses, they themselves, they're going to make these laboratory observations. So those in the CML, the clinical microbial laboratory, they're making the observations to see in the microscope. They can see what pathogen is actually present in this sample. And then again, our role, making sure that we're selecting and collecting these specimens. We're making observations from these. So we generate these results to assist these clinicians. Our role is to assist them to make sure that they are correctly diagnosing these infectious diseases and then therefore initiating the proper therapy or treatment. So again, the importance of high quality clinical specimens. So high quality clinical specimens are required to achieve an accurate, clinically relevant laboratory result. So the three components of the specimen would be one, that we select the proper specimen. And I use this example all the time because I think this one's pretty obvious. If a patient came into a doctor's office or a hospital and said, I'm having pain when I urinate, I don't think I'm going to take a throat swab of this patient, right? I'm not going to take a blood sample. Obviously if they have pain when they're urinating, I need to take a urine sample and see what's going on in that area. So again, that's what I mean by proper selection, that based on the patient's signs and symptoms and what's going on, we need to make sure that we're, selecting the right test. We're, collecting everything appropriately. So whether we ourselves are collecting like in a blood draw or, a throat swab or something of that nature, if we ourselves are collecting it, we collect it properly. But in the example with the urine sample, obviously, the patient will take that. So we make sure that we advise them on how to collect that properly. So the collection is really important to make sure we get an adequate amount and that, again, it is not contaminated. And then same thing with the proper transport. We need to make sure that one, it's transported to the laboratory in an appropriate amount of time so that we make sure that, in the event that, again, remember what happens with some microorganisms that sometimes when they leave where they're normally living, in this case, where they're causing infection, they, change in temperature, change in atmosphere, things of that nature may cause them to die off. And we want to make sure that we get that to the laboratory before that happens, but also we get that to the laboratory without any contamination. So the laboratory must provide written guidelines. So there's typically a laboratory policies and procedures manual that will advise nurses and staff on how to do these things to make sure that they are getting the specimens of the utmost highest quality. The person who collects the specimen, again, is ultimately responsible for its quality. So it's based on, making sure that we're not just selecting properly, but again, the collection and the transport are really important because we want to make sure that there's no contamination. We don't spill it to, things of that nature. We are essentially responsible for that. Even though, again, we're not the ones making the diagnosis, we're responsible for that specimen's quality. So specimens must be properly selected, as I mentioned, and properly collected. Material, so the specimens, should be collected from a site where the suspected pathogen is most likely to be found. So again, in pain during urination, obviously we're going to take a urine sample for urinalysis. So in the event that a patient has a wound that has now developed an infection, we're going to take a sample from that wound. So we're going to take a tissue sample or a sample of the pus that could be developing from that wound. So again, where that pathogen is probably located, that's where we're going to take these specimens. Specimens should be obtained before any type of antimicrobial therapy, if possible. Typically, we want to make sure that the patient has not started any type of antibiotic or an antiviral regimen, because sometimes that can make the specimen really hard to read because we've already started to try and kill it off. And it's hard to really tell which specific bacteria could be causing that then. So typically, more than likely, the patient hasn't started any type of antimicrobial therapy. That's why they're there. But we want to make sure that we that's kind of ideal that we get that beforehand. The acute stage of the disease is the most appropriate time to collect the specimen, meaning that when an infection, kind of colonizes in a patient's body before the patient is in really active stage of illness, we really want to try to get that right before they start developing all those different signs and symptoms. But again, even when they're in that active stage, that's typically when they're like, okay, time to go to the doctor. So we can still get adequate results from that. Specimen collection should be performed with care and tact, again, to avoid harming the patient. And a sufficient quantity of the specimen must be obtained as well to make sure that we have enough material for all required diagnostic tests. And I use the example with the urinalysis. Obviously, we want to make sure that the patient fills the cup as much as possible so that we have enough to read and perform that urinalysis. If the patient doesn't really have to go and only gives us a couple drops, that's not really going to give us an adequate amount. So we may have to suggest the patient drink some water and maybe wait a minute and then try to go again. All specimens should be placed or collected into a sterile container. Why sterile? Because again, we want to make sure that we're avoiding contamination. I'm not going to just pick up some random cup that, I find on the nurse's station and go ahead and say, here, go ahead and urinate in this, because whatever's in that cup could be what the laboratory picks up on the microscope, and it can be very confusing. So making sure that it's sterile. Specimens should be protected from heat and cold. Again, sometimes different microorganisms respond differently to temperature. So on their way to the laboratory, we make sure that we deliver them promptly. Hazardous specimens must be handled with even greater care to avoid any type of contamination of the courier, so the person who's carrying it, any other patients that may be nearby, something that could be harmful to anybody in the area. We make sure that we're even more careful with things of that nature. Whenever possible, a sterile disposable specimen container should be used. So most of the time, I keep using the urinalysis samples, those cups will be disposed of after the urinalysis is performed. The specimen container must be properly labeled and accompanied by an appropriate request slip so that in the laboratory, the person who's, taking the reading of this particular specimen knows what patient it belongs to, when that was collected, so that again, they have that appropriate timeline. So they have all these patients that they have to read all these different specimens, they make sure that they go in the order that they were received. Specimens should be collected and delivered to the lab as quickly as possible. So again, as I mentioned, as early in the day as possible to allow that sufficient processing time. So let's talk about some of these different clinical specimens. So some of the common ones that you guys, I'm sure, are familiar with. Blood. Blood is usually sterile as it travels through our bloodstream, but it is possible for bacteria to get into our bloodstream. The presence of bacteria in the bloodstream is known as bacteremia. Not the same as septicemia. Bacteremia is just the presence of bacteria there. May not always lead to infection. It's just that bacteria is present, but again, just like sometimes indigenous microflora, even though typically blood is sterile, it's present, it's there. Not a great thing. We want to try to get rid of it, but a more serious case of bacteria in the bloodstream would be septicemia. So you guys probably are familiar with the term sepsis. When a patient is in sepsis, there's all kinds of signs and symptoms that they are displaying, such as chills, fever, prostration. This is the presence of bacteria, and then even bacteria toxins within the bloodstream. So this is definitely the one you want to make sure you're familiar with that bacteria in the blood, septicemia. So what happens, we want to make sure that we prevent any type of cross-contamination, with indigenous microflora, so to make sure that we don't get any of that indigenous microflora from the skin. To prevent that contamination, extreme care is going to be taken using a aseptic technique. So using that surgical asepsis. So you guys, I'm sure, have all had your blood drawn before, or at least seen it done. And you guys, I'm sure, will get a chance to do this at some point too. But again, we know that an alcohol swab is typically used to wipe the area around the vein. You can see how this nurse is wiping towards the outside, so starting in the middle, because what he or she is doing is wiping all microbes. So again, not just pathogens. Any and all microbes need to be pushed away from where he or she is going to enter that needle. We don't want any of that indigenous microflora from the skin to be pushed into the blood through that needle puncture, because again, that indigenous microflora could become an opportunistic pathogen within the bloodstream. If you guys remember, opportunistic pathogens are, again, typically don't cause infections, but maybe when taken to a different area of the body could be thrown off and start contaminating it. And again, we don't want any type of bacteria in the bloodstream. So that's how we typically will take that blood draw. Another is urine, as I've mentioned that a couple times already today. Normally, urine is sterile within the bladder. It becomes a little bit more contaminated as it goes through the urethra during voiding because of the indigenous microflora that's present there in the urethra. So what we do when we advise the patient before they get ready to use the restroom and urinate into a cup, we advise them to use a clean catch midstream urine sample. And what that means is typically, and again, you guys, I'm sure, have all done this before, you're handed a cup and an alcohol swab. The purpose of that alcohol swab is to make sure to wipe the area around that urethra on the outside there because of that indigenous microflora that's present. And then when you start to urinate, you go ahead and do so a little bit and then collect. Because again, that's going to make sure it gets rid of all of the indigenous microflora that could be present. That goes into the toilet. But again, then the hopefully more sterile, or not necessarily sterile, could be contaminated with the pathogen that's causing the infection in this patient, is the only pathogen that we see instead of the indigenous microflora. So that's what I mean by the clean catch midstream urine. So typically, not that you guys have to know all the details with this, but a urine culture involves different parts. I'm going to show you guys a picture of these different steps here. We do a colony count. We isolate and identify the pathogen, and then we use what's called antimicrobial susceptibility testing. So what we do, the colony count is a way of estimating the number of viable bacteria that are present within that urine specimen. So that helps us to see, just based on that sample, well, then how many bacteria are present within this person's urine. So a calibrated loop is an instrument that's used, you don't have to know the size of it, is used to inoculate the entire surface of a blood agar plate. And I'm going to show you a picture right here. So this is what happens. Here's your calibrated loop. It is sterilize before entering into the urine to make sure that there's nothing on that calibrated loop. We enter it to the urine sample, and then you can see there's this technique to wipe that across a blood agar plate. What happens is the bacteria will start to grow on that blood agar plate, starts to respond. It starts to then grow. We can see, okay, here's the specific bacteria that is now present in this person's urine. So what's going to happen? We do what's called antimicrobial susceptibility testing, and antibacterial discs are placed on this blood agar plate, and we see the amount of destruction as that takes place. You can see the bacteria will start to die off around those antimicrobial discs, around those, again, this is what those antimicrobial discs are, is different types of antibiotics. We want to see which one's going to be most effective for this particular type of bacteria, whichever one has the most amount of destruction, meaning kills off. You can see that the bacteria starts to die off. You can see a bigger path. I mean, I think I have another picture of this a little bit later on that you guys will be able to see. That's the antibiotic that we want to use. And so that helps to see, that's what I mean by that susceptibility testing. So again, it was a calibrated loop that is going to inoculate the, that surface of the blood agar plate. Then overnight, the colonies begin to grow, and then we're able to see, about how much, how many bacteria are present. And then we can use we can use the antimicrobial disc to see which antibiotic is going to be more effective for this individual. And that helps us to see that. Okay, so that's a urine colony count. Okay, another sample, cerebrospinal fluid. Cerebrospinal fluid is taken in the event that we may suspect meningitis, encephalitis, or meningoencephalitis. These are all illnesses that involve the nervous system. The meningitis is inflammation around the meninges, right? Your membranes that surround your brain and spinal cord. Hopefully you guys remember that from anatomy. Encephalitis is going to be inflammation or infection in the brain. And then meningoencephalitis is the combination of the two. So it could be inflammation of both the brain and the meninges. So if one of these is suspected, then we need to take a cerebrospinal fluid sample. Nurses will not perform this procedure. It is collected by a lumbar puncture into a sterile tube. This is a surgical aseptic technique that is going to be performed by a physician only. It is considered a stat or emergency specimen in the laboratory. It's going to be something that's going to be processed before every other sample that they have. So here you can see the patient lies on their back, and the physician will then enter the needle into that lower back in the lumbar area, and then go ahead and collect the sample of cerebrospinal fluid. You can see why a physician is the one who will do this, because of the proximity with the spinal cord there. Okay. Sputum. Sputum is a common one as well. Sputum is a pus that accumulates deep within the lungs of a patient that has a lower respiratory infection, such as pneumonia or tuberculosis, something that's deeper in the respiratory tract. So not to be confused with strep throat or sinusitis that affects the upper respiratory tract. Oftentimes, though, the problem is sputum. Specimens that are labeled as sputum are actually just saliva. Saliva specimens don't produce the relevant information that is needed. Sputum is that, if you've ever had a really bad cough, so bad that sometimes you cough stuff up. I know that's kind of gross to think about. That's what we need from the patient, is that deep kind of mucousy, nasty stuff that comes up in the event that there's a lower respiratory tract infection. And typically that's pretty easy to do if they have that lower respiratory tract infection, because more than likely they're already coughing that up. But sometimes, again, the patient just provides us spit, and we don't want that. We need that, again, that deep cough. If TB is suspected, extreme care is going to be taken. Better specimens can be obtained through a bronchial aspiration or a transtracheal aspiration. But we want to try to get that obviously from that cough first. Throat swabs. So here, in this case, we really just need a sample of the patient's, not necessarily saliva, but we want to make sure that we're focusing on where that pathogen is present. So routine throat swabs are used to determine whether a patient has strep throat. So again, we're not wiping the inside of their mouth. We need to make sure we're deeper in the throat to make sure that we get, where that pathogen is causing that infection. And wound specimens, whenever possible. So in the event that a patient has a wound that is appeared to become infected, a wound specimen should be an aspirate. So meaning that's going to be pus collected by a needle instead of using a swab. And you guys probably already know why a swab is not great. When you use a swab, again, remember our skin contains indigenous microflora, and that swab is going to pick up that indigenous microflora. And we really only want to figure out what the pathogen is that's present in the pus. So again, it mentions there that specimens collected by a swab are oftentimes contaminated by that microflora. In fecal specimens, so ideally fecal specimens should be collected at the laboratory right away because of, the colon. The colon has there's going to be a vast change in temperature and even acidity level, so the pH level, when that is collected. So we need to make sure that that's processed immediately. So it's taken in the laboratory itself, and again, to prevent a decrease in temperature, which would allow the pH to drop, and then therefore causing the death of certain types of bacteria that cause infections in the intestinal tract. So like Shigella and Salmonella. So bacteria in fecal flora, oftentimes obligate, aerotolerant, and even facultative anaerobes. So again, we want to make sure that that change in not just temperature, but atmosphere is processed right away. So a combination of direct microscopic examination culture, biochemical tests, and immunologic tests may be performed to help to identify whether it's gram-negative, gram-positive, fungi, intestinal protozoa, and intestinal hemolymphs that are associated with these fecal specimens. Okay, so really in this kind of ending up the chapter here, I want you guys really to just be familiar with the lab, that these clinical specimens are submitted to this lab. So they're submitted to the Clinical Microbial Laboratory, which is part of the Pathology Department. Remember, pathology is just kind of a broad term for all diseases, but again, we are focusing right now on infectious diseases, meaning that diseases that are caused by pathogens, that are caused by bacteria or viruses or fungi. Whereas again, we know that there's more diseases other than that. So it's part of the pathology department. So oftentimes this pathology department is referred to as the lab. It is under the direction of a pathologist who is a physician that specializes in pathology. And there are two major divisions, but again, the main thing I want you guys to be familiar with is just the lab itself. There is anatomical and clinical pathology, as it kind of breaks that down here for you on this diagram here. Excuse me. The morgue is part of the anatomical pathology. Histopathology, which would be like tissue samples, again, that would be part of the anatomical. Cytology, which would be focusing on different cells and different, that's part of that. Cytogenetics, which would be your genetics, so it would be cellular and thing like that, cellular genetics and things of that nature. And then that particular lab includes electron microscopes. But the clinical pathology, this is focusing on clinical chemistry, hematology, which is focusing on blood and things of that nature, immunology, so the blood bank is there, and again, the clinical microbial laboratory is part of that. So again, like I said, you guys don't have to know all these different divisions when we break that down. The main thing, I'm going to actually finish here because the main thing I want you guys to just be familiar with is what was on that previous slide, that these clinical specimens are then submitted to the lab, and that's where these readings are going to take place. And again, these individuals that are in the lab aren't making these diagnoses either. It's again, their observations and then helping us to see what pathogen is present that's going to help that physician or clinician ultimately make that final diagnosis to begin treatment for the patient. All right, guys, so that's the end of chapter 13. Again, that's our role in helping with the diagnosing of infectious diseases. And as usual, guys, if you have any questions, let me know.